Today's seminar is about commissioning, and we've been on, as you people in the NHS like to call, a journey through these seminars, and we've covered a lot of themes such as leadership and culture, the patient experience, and so on, all of which overlap. We come at the end to commissioning, and I think it's possibly appropriate for me to be the last one of these seminars, because it may be, particularly in the current scene, shifting as it is, that commissioning is one of the last most important levers left in the national system and indeed the local system to get right what it is that patients and the public actually want by way of their service, and the bit that really is central to the Mid-Staffordshire inquiry, to do something about quality. Those who've been here before will be familiar with that slide, which reminds me of my terms of reference, which on this occasion emphasise commissioning and the culture and systems within that. And Sir David Nicholson's evidence about the opportunity presented by this inquiry. It's daunting for me and a privilege for me to be asked to do this, but there's no way that I can get anything near like the right answers unless I'm helped by people like you, which is why we've invited you here today. As I've said on all previous seminars, what I'm interested in is for you to bring your personal experience, large as I know it is, as well as, if you wish, your organisation's experience. But for those of you who haven't been here before, I have to warn you that Chatham House rules do not apply. This is a public inquiry. We espouse the principles of transparency, and I reserve the right to put anything you say in my report. So it's not any pressure on me, it's a bit of pressure on you. Commissioning. Some might wonder why difficult as commissioning is as a concept. The idea of monitoring the result of the commissioning process seems so strange to the National Health Service. This building, not very attractive you may think, is closely associated with the Stafford inquiry because it's just across the road from where we have sat for 133 days listening to our evidence. When we started, that was a hole in the ground, and they handed the keys over of a £33 million building project to the Staffordshire County Council in September. Now, crawling over that site on behalf of the public, a building project commissioned by the council, were of course any number of quantity surveyors inspecting every rivet, bolt, the way the scaffolding was put up, and so on. And if it wasn't done right, under the terms of a contract, which specified what it was that was to be done, it would be put right. Or if it hasn't been put right, some of my colleagues are no doubt at this very moment working out a claim for damages about it. But the point is that that building wasn't made simply by the council handing over a sketch plan to a building contractor and letting them build a building and accepting the result. If what they wanted wasn't delivered, they weren't paid for it. If it was delivered late, I bet you there was a penalty clause in the contract. So they call that quantity, but there may be some quality in that. When that man commissioned Mr. Holbein to paint that portrait, I suspect that Mr. Holbein realised there were consequences attached to not achieving the approval of his commissioner. Unfortunately, I couldn't find the slide of the rather more apposite picture, which is thought to be by Holbein, but is said to, on the slide I could get, as be an unknown artist, where His Majesty required the photoshopping into the picture of his family, one of his recently deceased wives, Jane Seymour. So but this man knew about commissioning, you might think, for quality. And how is that done? Well, you produce the goods, someone reviews them, and if they're not any good, you reject them, and again, no payment follows. Moving on to the National Health Service, it might be thought that commissioning for quality shouldn't have been a strange concept. It's a statutory obligation and has been since the concept was first provided. But what happened in Mid Staffordshire? Well, we know only too well, don't we? It would be unfair to say that the Primary Care Trust paid no attention to these results in 2007, when Mid Staffordshire was found to be one of the worst performing trusts for unexpected mortality in the country. But not much, you might think, effective happened about that in terms of the commissioning process. To be fair, they may have been told by the Trust Board that they didn't believe they had any significant clinical problems. That comes from a Trust Board report in June of 2007. They may, like Monitor, have been reassured by the assurances in December 2007 that they did not have a problem with mortality, or misled by the academic research. So all those things might be possible. But in the meantime, during that year, what was happening at the Trust, whose services this Primary Care Trust was commissioning? These people, and people like them, were suffering grievously. During that year, in fact, those of you who've been here before will have heard me say this before. In April 2007, the very same month that the HSMR came out, poor Mrs. Astbury died because, being an insulin-dependent diabetic, known to the hospital as such on admission, she wasn't given her insulin, she wasn't given special dietary care, and her blood sugars weren't taken or measured as they all should have been. And at various points in the system, nurses either didn't know or didn't care enough to ensure that she was given life-sustaining and very simple treatment. There was an investigation by the Trust in-house solicitor, who reported at some point during 2007 that all these things had happened. But he also said in another part of the report that the evidence persuaded him that this wasn't an isolated event, that there was evidence that this sort of thing had been happening. The report for this serious untoward incident went to the Strategic Health Authority. I don't know at this moment whether that report did. I'm not sure whether the Primary Care Trust got to hear about this, but rather doubt it. But certainly there was no reaction to it. One might have thought that anyone reading this report or knowing what lay behind it would have felt reservations, if nothing else, when approached by Monitor to ask for a view on whether this trust was fit to become a foundation trust. That's the bit saying that it was not an isolated incident. If we move on, though, into the world of world-class commissioning, December 2008, the panel assessment of this PCT and how it was doing with world-class commissioning, at a time I should remind you that the Healthcare Commission had announced its investigation and was continuing it. Now, this is only an extract from part of a number of slides about this. And it would be fair to say, though, the tenor of the whole thing is completely positive about how this trust has coped with the challenges of, big as they were, of reorganisation. It's done big things about the financial challenge. And there's all sorts of other things that are mentioned there, which I have to say, for the outsider and a member of the public, would be really quite difficult to understand what they mean. But one observation I had when looking through that particular report, of which this slide is just a sample, is that I couldn't see anywhere a mention of the word quality. I couldn't actually see a mention anywhere of the word patient. And it does make me wonder whether the commissioning process that doesn't or didn't emphasise those things, which was after all the purpose of having commissioning in the first place, whether there's not something wrong about it. But in the meantime, at Stafford, things like this were happening. Those of you who've been to my seminars other seminars will have seen this slide before. Patients and their relatives were undergoing horrors at this trust. And so they continue. One might ask in all this, where were the general practitioners? There are two relevant main commissioning consortia. And when the balloon went up and the Healthcare Commission moved in to investigate, the PCT asked these consortia group whether they knew of any concerns about this trust, having previously heard none, apart from an argument about discharge letters, which will be common, I'm sure, to many hospitals around the country. Hadn't heard any. So they held a meeting, and they asked each of the commissioning consortia to hold a meeting of their general practitioners. And each of them came up, this is the Cannock Chase one, but the same thing happened in the other consortium, came up with a 3 or 4 page letter of concerns that general practitioners in the area had. So what have the general practitioners done about those? Well, to be fair, they had, the evidence I've heard, some of them at least did something. They would have complained to the trust. But two things they didn't do. One was there was no system in place for them to gather together the information, so what on its own might have looked quite trivial when put together with a number of other complaints might have showed a pattern. But secondly, they didn't take their concerns to the people who were in reality responsible for paying for the service and commissioning the service, which was either their commissioning consortium or the PCT. So it was only after the event that the GPs were brought into this process. Now, one would hope that in future that's less likely to happen, but I fear not if the way in which commissioning is done continued as it had done in those years. I know we're going to hear from Dr. Cunningham later, but just give him advance billing. His conclusion I put up there on the slide, that within the local reporting systems employed by the NHS, no concerns about the hospital trust came to light. With hindsight in undertaking this review, evidence of poor care has emerged that was not collated, an important word, or challenged, even more important, by the PCTs or SHAs at the time. And in addition, the Public and Patient Involvement Forum was largely uncritical of the hospital. And it is of concern that issues of poor care were able to go undetected. Well, the good Dr. Curling told me at the time, of course, was sitting in the Department of Health. It may be, I don't know about his language, but my language would be rather less polite than that about something as important as what had gone wrong there. So I just end with 2 quotes, which again will be familiar to those who've been before, from Mr. Street, who was the partner of the poor Mrs. Asprey, about what they want out of my inquiry, out of the lessons to be learned. I don't want anyone else to suffer that. And Mr. Jeff Guest, I'm fed up with people talking about lessons learned. The lessons are really about basic care and attention and having the right systems in place. The NHS has still not got this right. Now, I understand that it's all a lot more complicated than that, but I do warn you, and I'll say it at the end of this one, I have heard quite often during the course of my seminars the word complicated. The fact that something is complicated is no reason for not getting it right, in my view, if you start from basic principles. And the other thing that has gone through some of these seminars has been, when we've heard really quite revealing things from outside speakers, is, oh, well, that's different. Well, it may be different, but sometimes there are lessons to be learnt from differences and from outsiders. Maybe that's where a public inquiry comes in, to allow that sort of thing, a breath of fresh air, to come in. But at the end of the day, what I'm really interested in to hear is your views, rather than seek to express mine. Indeed, anything I have said today, as you will fully appreciate, is not a conclusion, and may not appear in my report like that. I've got to consider a vast range of evidence, of which I've only shown you a somewhat challenging snapshot. But thank you very much for coming.